Thank you so much. I'm really happy to be part of the SOSA conference today. And I'm just getting my screen up.
Sure.
Thank you. So today I'm going to talk a little bit about health behavior and chronic disease broadly, but I am a smoking cessation researcher. So I am trained as a psychologist. I did my PhD in counseling psychology, and I've been focused on smoking cessation research for the past decade. Some of the populations of interest have included smoking among African Americans, hospitalized patients, and most recently I've been focusing on pregnant and postpartum women. So as I talk about health behavior and chronic disease, I'll move into looking at the ecological model, focusing on tobacco as the example. But this can also apply to other health behaviors. And then lastly, I will discuss a project that I'm currently working on. So if we think about modifiable risk factors for disease, some of the big ones are really um, avoiding excessive alcohol use, getting physical activity, eating a healthy diet, and not smoking. Others could include, getting adequate sleep. But these modifiable risk factors, these health behaviors, have an influence on us developing cancer, heart disease, lung disease, and diabetes. So, some people do, there's genetic predisposition, there are other factors that could happen, but what we can change is our health behavior. However, our health behavior doesn't occur in a vacuum. Like often we think about health behavior as very individual. So you should stop smoking. If you would just, if you're motivated enough, you would quit. But I want to look at some of the influences that go into whether or not a person quits smoking or, eats healthy, those kinds of things. Um, but first, I just wanted to highlight some health disparities as it relates to tobacco use. So in the United States, African Americans, they tend to be lighter smokers, and the same for Latinos as well. So they smoke fewer cigarettes per day, but compared to white smokers, they're at greater risk of dying from tobacco-related disease. And what we see is that African Americans and whites have very similar smoking prevalence. Um, Over the past, let's say, 50 decades, or 5 decades, sorry, 50 years, we've seen smoking rates drop across the United States to about 15%. So there's been a dramatic decrease in smoking. Smoking used to be very normalized. People used to smoke on planes. You would buy a plane ticket and indicate, you know, uh, if you wanted to sit in the smoking or non-smoking section. However, there was no way to remove cigarette smoke um, from the non-smoking section. You just always were exposed. And in the past 10 years, most places I go to now, I would be shocked if people were allowed to smoke indoors. So there's been this move towards smoking being not the norm anymore. So it's no longer the norm. However, not all members of the population have benefited from that change. So, for instance, people with mental illness and substance use disorders have twice the smoking rates of the general population. And there might be some factors such as, the stereotype of, like for AA, is of people, smoking outside the AA meetings. And there is now a shift, but people had sort of, even healthcare professionals that sort of said, okay, they're getting rid of their cocaine use or their alcohol use, let them continue with cigarettes. But you can have, you know, with the problem with continuing to smoke and continuing to use other forms of tobacco is that people die from this. So people get heart disease, they get cancer. And so it's critically important that all members of our society continue to benefit from reducing tobacco use. We also see that lower SES individuals have higher smoking rates. And I pulled this graph from the CDC, and it's very striking. The column in blue are adults with less or is less than adults with less than high school education, whereas the column with red or in red are adults with a college degree. And you see that among adults with less than a high school education for cigarette use, 30% are using cigarettes, and this is recent data, whereas it's 10% among those with a college degree. And we see fewer differences with cigars and smokeless tobacco. So as we think about sort of the levels of influence on health behavior, I wanted to just take a look at the social ecological model. Okay, so at the macro system level, we've got policies and mass media. At the exosystem level, we have the communities, the mesosystem, institutions and organizations, the microsystem, social influences and friends, and then we have the individual. I'm just going to go through the first three levels, and then as we get into my specific study, we'll focus more on sort of the meso level, the microsystem, and the individual. So I mentioned before some of the policies that have helped to influence tobacco use. Some other policies include restricting tobacco retail locations near schools, and also tobacco 21 laws. One of the things to note with tobacco use is most people who start smoking, they start smoking as a teenager. So 15, 16 people start smoking. And often when we start seeing people in healthcare environments and encouraging them to quit, they've been smoking for 15 years. They've been smoking for 20 years. Can you imagine doing something, let's say 5 to 20 times a day for 15 years? Like, how hard would it be to change your behavior? And then imagine doing an addictive substance 5 to 20 times a day. So it's not just a habit that you have, it's an addictive habit. And so if we can get kids not to start smoking, then that's going to have a huge impact on our tobacco-related outcomes in the next few decades. There's also been limits on tobacco advertising, tobacco sponsorship of events, and the ability of tobacco companies to give out free samples. Now, these policies are very important. Tobacco use isn't just a habit that happens in a vacuum. We actually have tobacco companies that actively push back against legislation limiting their ability to advertise, limiting their ability to sell, limiting their ability to produce whatever flavor that they want. And for decades, they've also specifically marketed to African Americans. Tobacco companies were known to give out free samples in African American communities and to advertise specifically targeting African Americans. They tended to capitalize on the preference for menthol cigarettes and to really focus their marketing efforts. And so when we have policies to protect individuals or to limit how the tobacco companies can market their products and even the sponsorship of events. Tobacco companies would sponsor African American events and sort of portray themselves as supporting the African American community. And so it made it difficult, even within the past 10 years, the NCAAP had come out against banning menthol for the reason that many African Americans smoke menthol, when in fact we want people to quit. So having getting rid of menthol cigarettes would mean that more African Americans would quit, which is the outcome that we want, because that means less cancer, that means less COPD, that means less heart disease. The other thing to know or to think about is our neighborhood factors. So some research is indicating that having a tobacco retail outlet near your home means that you're exposed to advertising, you're exposed to cues to purchase cigarettes. So let's say you're on your way home from work, you're trying to quit, but you feel a craving, or every time you stop at the gas station, you've bought cigarettes. So you pull into your gas station and you buy cigarettes. Okay, so some research indicates that it makes it harder for people to quit smoking. And what we find is that in both rural and urban communities, there are higher with higher proportions of African Americans. We see more tobacco outlets in relation to the population. Okay, and so there's this greater exposure. And if you think about this in terms of other health behaviors, such as neighborhood factors related to physical activity or neighborhood factors related to healthy eating. If you live in a neighborhood that's not safe or that doesn't have sidewalks, that might curtail one of the easiest activities to pursue, which is walking. Many people, they either walk in the community for exercise, for leisure, or they might, walk to a local grocery store, a local shop. And if your neighborhood doesn't have that set up, you have people, engaging in less physical activity. Similarly, with nutrition, if there aren't places that sell fruits and vegetables, but there are 10 fast food restaurants, that's also influences people's health behaviors. So it's important for us to think about like the context that people live in and how that influences their health behavior, rather than thinking about their tobacco use, their activity level, their alcohol use in a vacuum. At the institutional level, I wanted to think about tobacco treatment. So this diagram shows pharmacy claims for smoking cessation medications in 2010 to 2013. So we had conducted a study looking at Medicaid billing. So Medicaid covers or provides insurance, health insurance for pregnant women who are low income. Okay, so if a woman becomes pregnant, she can apply for Medicaid. And Medicaid covers a large percentage of pregnancies in the United States and in Kansas, where this analysis was conducted. So in 2010, Medicaid began covering smoking cessation counseling as well as medications for pregnant women. I'm going to add a caveat. So the guidelines for tobacco treatment state that use nicotine replacement only if behavioral counseling doesn't work. And that's because nicotine is not healthy for a pregnancy. But nicotine replacement, a woman who's smoking is getting nicotine and carbon monoxide and a number of other harmful chemicals that can affect her and her pregnancy. So nicotine would be used for a limited time period to help the woman to quit. Bupropion is an antidepressant that's used for helping people to quit, but it's also used for depression. So for the reason of depression or the indication of depression, providers can also provide bupropion. We also have varenicline. So varenicline is not particularly recommended for pregnant women. It could be recommended for postpartum women who are not breastfeeding. So one of the things in this analysis, though, we were not able to tease apart whether or not bupropion was used for smoking cessation or whether or not it was used for depression. Okay, so not shown on this table, not shown in this graph, sorry, there were two claims in 2011 and 2013, or I think probably 2011, 2012, and 2013. There were two to three claims per year for smoking cessation counseling. And if we look at the graph, we see that there were approximately 13,000 Medicaid covered births during that time, and about 10% of pregnant women smoke. So we would expect that there are at least 1,200 or 1,300 pregnant women who were smoking, but yet there were only 2 claims. And so there are a couple of issues. One, it could be that people aren't billing, but the codes were there to encourage providers to bill and to provide counseling. And we see that use of nicotine replacement was also very low, with less than 100 claims per year. We saw the most use of bupropion, but again, we can't tease out whether or not this was for smoking cessation or for depression. So the key thing here that I want to take away is that there's a gap in tobacco treatment, and tobacco treatment doesn't take a long time. We use a very simple model. It could be ask, advise, and refer. So there are free resources such as the Quit line for women to call, and who will place proactive calls to women. So that leads us to my current study. So just some additional background. 90% of women who smoke before becoming pregnant will be smokers by the time their baby is 1 year old. We find that a lot of smokers, 50% of smokers quit during pregnancy. So many women, they find out that they're pregnant and they quit right away, often even before going to their provider. The women who don't quit, though, they may have more going on. They may have a greater addiction. They may have fewer perceptions of health risk. They may just, I had another baby, I smoked, that baby's fine. But it might take more effort to help get those women to quit. Okay. But once the baby is born, many women, I've heard from delivery nurses, many women start smoking. A few even go outside and smoke that day. But pregnancy is a good time to help women to quit for a couple of reasons. One reason that really stands out to me is if we can get women to quit smoking in their childbearing years, so by the time they're in their 30s or 40s, we can cut down 90% of the excess risk of lung cancer. So that gets them pretty close to having the same outcomes as a non-smoker. But once you continue smoking additional decades, the risk remains high even after people quit. I mean, again, it's always a good time to quit. People's outcomes are better, but I think this is a critical time period to get young women to quit. And if people are young and healthy, often, we might go in, for those of us who are up to date on their healthcare visits, you might go in once a year. But pregnant and postpartum women, they're going to more than 20 primary care, obstetric, and pediatric visits. And if you have women who are uninsured or underinsured and low income, they may be eligible for Medicaid during this time. So they may have greater access to healthcare than they usually do. One of the gaps, as I mentioned in the previous slide, is that tobacco treatment is not routinely provided. However, most providers' offices do ask women about their smoking status. It's often on forms that women complete to come into the clinic. So it's asked about. It's just that the other steps of follow-up have some gaps. So the goal of this work that I'm doing is to develop a text message intervention to support smoking abstinence among postpartum women. Okay, so my goal is to get women to quit and to stay quit long term. Now, there are a variety of interventions to help women with quitting smoking during pregnancy. And so what I want to do is to supplement what exists to maintain that long-term smoking abstinence. So why text messaging? Well, it's low cost and it's widely accessible. The majority of low-income women have cell phones. Okay, so we see people moving away from the landlines. people have cell phones, and then text messaging is low cost. Our uptake of the quit line is very low. And one possible reason is that on a lower end plan, minutes um, minutes are like a precious commodity. So spending a lot of time talking to somebody might be seen as a drain on resources for your phone, whereas text messaging, people may often have unlimited text, or texting is just cheaper. And the other part is that it might fit into people's schedules more easily as well. Text messaging interventions are effective for health behavior change. The other few things that this study wants to address, or this intervention should address, is the loss of continuity across transitions of care. So as women move from prenatal care to their pediatrician, there might be a lapse in kind of the tobacco treatment or the follow-up that women have. The other part is that even though women may not be a current smoker at the time she's in prenatal care, if she smoked early in her pregnancy or before becoming pregnant, she may be at risk for returning to smoking. So as the previous slide said, 70% of women who quit relapse by the time their baby is 6 months. And there's also a lack of services for participants who are not interested in quitting. So women who are not interested, if they're referred to the quit line or they're referred to a smoking cessation text message program, usually you have to commit to setting a quit date in the next 2 weeks. So we wanted to be able to tap into, get connected with women who are not interested also, so that when they are interested, we can get them into a tobacco treatment program right away. So the goals of the intervention would be to be assessing women's smoking status, to provide them with messaging around motivating them to quit smoking, and also referral to a quit program if they relapse or if they're ready to quit, and updating their provider, so helping to close that loop and getting them additional support. So in order to develop this text message intervention, we've been conducting an observational study. And so within the observational study, we wanted to understand how women's tobacco use changes over time. And we wanted to understand their perceptions of tobacco treatment quality from their healthcare providers, both during pregnancy and postpartum. So our goal was to recruit a cohort of 60 pregnant women and follow them to 1 year postpartum. And they could be current smokers or they could be quit. So either smoking status. They just had to have smoked within the 6 months before becoming pregnant. So we conducted a few different kinds of surveys with them. So a baseline survey that everybody in the study needed to complete, 4 follow-up surveys. So baseline, a third trimester, 1 month postpartum, 6 month postpartum, and 12 months postpartum. Then post-clinic visit. So they had about 6 surveys that we would send to them within a week after completing their a provider visit. And then we sent them weekly texts to ask them if they smoked in the past week, and if they did, how many cigarettes did they smoke. So we were able to enroll 62 women. And this is not a representative sample. So the differences in our enrollment of white and multiracial and African American women is more about the sample that we were able to recruit as opposed to representativeness. But we had quite a diverse group of women in our sample, which is good. We see, one of the things that we see is that women who were former smokers who'd quit, they're more likely to be employed full-time than are current smokers. And that could point to issues with just, employment stability, income, things like that, that could be impacting women who are having a harder time quitting. We see that most of the women who are current smokers at baseline were also everyday smokers before becoming pregnant. About a quarter of our current smokers are also using other tobacco. 20%, almost 20% used alcohol in the past month. About 27% used marijuana in the past month. And then current e-cigarette use is a little bit lower, but it's 10% among current smokers and about almost 15% in our former smokers. And then just another point to note, and this is related to that microsystem, smoking in the home. 85% of former smokers have smoking restrictions in the home, so that nobody is allowed to smoke anywhere inside the home, whereas only about 60% of current smokers have those kind of rules. And we also see a gap. 65% of our current smokers did not get smoking cessation assistance at baseline. So we recruited women from the clinic, so they had already seen their provider, or most typically that they had, and still about 65% of them are saying that nobody provided them with assistance. Our retention rates so far have been good, so we'll finish our follow-up in June of next year. But so far, 85% have completed the surveys on the tobacco treatment during prenatal care and 3 well baby visits. We've got a 93% completion rate for the 6-month postpartum survey, and only 3 women have been lost to follow-up so far. So what this means is that, there's potential feasibility to following women using text messaging and online surveys. And so I think that indicates that there's, for our intervention, this could be a useful way of keeping in touch with women. As we pointed out, there are low rates of smoking cessation intervention, even in this population. So these women were all recruited from clinics or healthcare facilities. And then pregnant smokers are at higher risk for other tobacco use and are less likely to have home smoking restrictions. Okay, and my current project is funded by NIDA, a K1, so that's a career development award. And I just wanted to highlight my collaborators who have been working with me on this project and papers coming from this project. And now I just wanted to open up for questions.
All right. Thank you so much, Dr. Scheuermann. Any questions? You may raise your hands, or you can also leave your questions in the chat and we'll get to it. Any questions? No question? Wow, okay. So we currently our participants are still thinking about it.
Okay.
We currently am not seeing any hands raised. Okay, I'm not seeing any questions here for you, Dr. Scheuermann. We thank you so much. We really do appreciate your enlightening us on health behavior and some of the health disparities that we may come across in our society. And we do appreciate you sharing with us this afternoon. Thank you much.
Well, thank you so much.